Let's get started. I want to welcome everybody to this really special presentation by our good friends with Stanford Care-ValleyCare. My name is Steve Van Dorn. I'm the President and CEO of the Pleasanton Chamber of Commerce. I would like to introduce my team member, Susie Weiss. It is to my right on the screen. So Susie is our communications and events person. So Susie, thanks for being here. And I'm sorry, I'm just letting people in here. And also want to introduce the chair of our board, Tracy Lewis-Taylor, who is also the chief operating officer for Stanford Care-ValleyCare. She started there in February 2017. I'm sure it just seems a little bit longer than that, perhaps, right, Tracy? And before that, but before I get to that, in this role, she's responsible for providing strategic leadership and management for all hospital operations, including human resources and nursing operations. In addition to her role as COO, Tracy serves as the chair of our board. Previous to her move to California, Tracy served as vice president for operations for New York Presbyterian Lawrence Hospital, overseeing hospital operations as well as operating and capital budgets and implementing clinical strategy. She also served as director of clinical services at New York Presbyterian, responsible for operations of the oncology and cardiology service lines. Tracy joined New York Presbyterian in 2006 as a Six Sigma Black Belt. Tracy has held roles with Tenet Health System and the healthcare consulting firms of Cap, Gemini, Ernst & Young, and Arthur Andersen. But before I hand it over to her, I just want to ask you to please, if you have any questions, type them in the chat and we'll answer them when appropriate. And we also are expecting another speaker to join us here shortly, Dr. Scott. And we want to thank you for joining us and really want to thank Stanford Care-ValleyCare for their partnership and putting this together for us. So Tracy, yeah, once you're finished there, it's all yours. Oh, she's in the middle of something. So, okay, I think we're ready now.
We are ready. It's never dull here. So yes. Thank you for your patience. And Steve, I appreciate the warm introduction. We are being joined today by my colleague, Dr. Jake Scott, who's a board certified infectious disease specialist. He was having a little computer difficulty, so we're going to go a little bit out of order in terms of how we intended to share information today. Dr. Scott will spend some time talking about COVID, talking about the vaccine itself and some of the clinical components of the vaccine and the effectiveness. He'll also spend a little bit of time talking about the different strains of COVID that we're starting to see across the country and certainly here locally, and what the implications for those strains might be. My intention was to really focus on the operational topic of vaccine distribution and vaccine administration. So we're going to flip, and I'll start with that conversation. We'll have Dr. Scott join when his computer reboots. So without further ado, and actually let me pause. This is really intended to be an interactive dialogue and interactive session, opportunity for you as the audience to ask questions and to get more information than maybe what you see or hear on the news, or maybe dive a little bit deeper into a particular topic. Since we are so flexible and nimble, and I see that Dr. Scott has joined, we're going to reorder this one more time, and I'll have Dr. Scott kick us off if you don't mind. And I'll start with a brief introduction. So I mentioned Dr. Scott is a board certified infectious disease specialist, which means that he provides general infectious disease care within our inpatient and outpatient settings, with a special interest in COVID-19, multi-drug resistant organisms, HIV pre-exposure prophylaxis, and something that I really can't pronounce, which is which we were talking about as being
Valley fever.
I'm sorry?
Yeah, it's a fungal infection you call valley fever. Yeah.
So every day I learn something new, which is great. One of the things that I really appreciate about Dr. Scott and his background is really his ability to focus on diverse patient populations and providing compassionate and high quality care. That's something that's really important to us as we serve a broad community. So really appreciate that this is something that he's very much interested in as well. He's a local Bay Area guy, which is fantastic, and inspired to work in medicine as a HIV test counselor in San Francisco. So that's where he's sort of born and raised in terms of career path. Fascinating, studied literature and creative writing in college, so far cry from medicine, but values the narrative aspect of medicine and the importance of drawing out the story behind the diagnosis. So again, something that I think is really personal when we think about our community hospital and understanding not only how diseases show up in our community, but perhaps why, and understanding root causes behind that. So we welcome Dr. Scott to the forum today. Thank you for being here, and thank you for talking to us a little bit more about COVID.
Thank you so much, and thanks for your flexibility and patience. My computer just crashed, but hopefully it's going to stay with us here. So I'm going to share my screen. You see that? Great. Okay. So I'm going to talk about COVID-19 vaccines, and then I'll touch on the variants as well. There is obviously a lot to talk about, so I will leave time for questions afterwards. So to begin with, let's see. Can you see my next? There we go. So vaccines have a very long history, going back to at least the year 1000 in China, when they used some material from a virus that, or material contaminated with the virus, to see if that would provide protection. And this basic principle of vaccines has been in existence and used for quite a while, but it really wasn't until the smallpox vaccine that was developed after some experiments with the cowpox virus that we started to use vaccines in humans. And they've been, I would say, clearly one of the greatest medical achievements in history. They've saved countless lives. It's estimated by the World Health Organization that since 2010, between 2010 and 2015, vaccines have prevented about 10 million deaths, and have also obviously prevented many more illnesses. Thanks to vaccines, we've eradicated horrible diseases like smallpox. And so vaccines, I think it's confusing to a lot of people as to how vaccines work. And so I don't want to take that for granted. But so basically, the fundamental principle of a vaccine is that you take some component of an infectious agent, whether it's just a little tiny part of a protein or part of the virus itself that's just been weakened to the point where it can't cause infection. And you basically just introduce it into the body so that the body's immune system can recognize it and say, hey, this is what we should look out for. So if we are infected with this, we know what to go after. So that's basically the fundamental principle of vaccines. So the first two COVID-19 vaccines have been based on mRNA technology. And I think that this has caused some concern, some questions, just because the vaccine technology sounds relatively new. I think it is important for people to know that there's a long history of studies that have looked into the use of mRNA, which is messenger RNA, for the sake of various medications, cancer treatment, and for vaccines. So it's been studied at least since 1989 for the use of vaccines, and it's been used in studies for vaccines against other illnesses, not just COVID-19. It's also even been used for a different relative of SARS coronavirus 2, and that's MERS, or Middle Eastern Respiratory Syndrome coronavirus. So this is not, it's not like, my point is, it's not like this is technology that was just suddenly whipped up in a lab, in February of 2020 or January of 2020, and then, immediately injected into people with no prior experience. There's been, years and years and years of attention and investigation into this technology. It's also important to know that messenger RNA is it's the component of genetic material that is not in the nucleus. It's in the cytoplasm and basically provides instructions to the cells to make proteins. And so the mRNA, the messenger RNA, does not interact with the DNA. So the DNA, and I think I thought I had a slide on this, but so DNA is the genetic sort of blueprint that's inside of the cell's nucleus. If you remember from high school biology, or if you had undergraduate or graduate studies in this, you would know. And then that blueprint is then transcribed into RNA, and the RNA serves as fundamentally the instructions for the cell to make protein, and the protein is what then provides our bodies with various functions. And so the messenger RNA in the COVID-19 vaccine, it doesn't go into the nucleus. It's impossible for it to go into the nucleus, and it therefore cannot interact with the DNA. And I mentioned this just because a few months ago when these vaccines came out, I heard a number of people raise that concern. And part of it, I think, has to do with misinformation that's been spread quite rampantly through social media. It's also important to know that this particular vaccine cannot possibly actually give someone COVID-19 itself. So the messenger RNA, it's a set of instructions in a string of molecules that our cells have in them at all times. And these particular instructions basically tell the cell to make a particular protein that's unique to the SARS coronavirus called the spike protein. And that spike protein basically acts as sort of the key to start the engine of infection. So the cell itself, or I'm sorry, the virus itself has on the outside these spike proteins that then help the virus dock onto human cells and start the infectious process. So this messenger RNA encodes this spike protein, and then it's packaged. So RNA itself is very fragile. It wouldn't get very far if you injected it. It would just disintegrate right away. So it's packaged in a delivery sort of package of lipids. It's called the lipid nanoparticle package. And that's just basically a very, very small droplet of this fatty substance with a little bit of sugar. And that basically just sort of buffers the RNA and allows it to get into nearby muscle cells after the injection. Also note that this is not delivered into the bloodstream. So these vaccines don't go throughout the body, go into the brain, etc. It's just it's your typical sort of vaccine shot goes into the muscle. The nearby muscle cells take up this lipid nanoparticle. The lipid nanoparticle just kind of dissolves away. It's easily metabolized, perfectly harmless. And then the messenger RNA resides in the cytoplasm, not the nucleus, as I said, and gets translated into the spike protein. That spike protein then gets excreted to the cell surface, taken up by immune cells, which then teach your body how to make antibodies, and also stimulates various other parts of the immune system other than antibodies. So vaccine trials typically involve 3 phases prior to when the vaccine's approved. And the COVID-19 mRNA vaccine trials were typical of your average vaccine study. Okay, so a very common question that I hear is, wasn't this rushed? Do you really feel like it's safe given how fast it was developed? Well, yeah, it was developed at record speed, but this is also the worst pandemic that we've had in 100 years. And there was all this fantastic scientific research that went into the technology. technology itself allows for it to be developed and produced quite rapidly, just by the nature of the technology. And because of Operation Warp Speed, these phases were basically compressed in that there was no significant financial risk, since the government put so much money up front for companies to develop these vaccines. So instead of waiting for financial investments to take a vaccine from phase 1 to phase 2 to phase 3, they were able to just go right through them, and even had some overlap. So these were huge studies that were typical of your average vaccine trials. And this just summarizes basically what I said. So there are a number of reasons why I would say that these vaccine trials were expedited. They were not rushed. And it's very important that the community knows that these vaccine trials were held to the same safety standards as we would expect. When it comes to vaccine safety, it's just absolutely imperative that a vaccine be proven to be safe before it's given to healthy people. It's just, I can't emphasize enough how important that is. The FDA, for instance, would not take any risk when it comes to vaccine safety. So briefly, like I said, the trials were large. So Pfizer used 45,000 volunteers. Moderna used 30,000 volunteers. They used studies at various sites throughout the US and in some other countries as well. There was quite a diverse demographic in both of these studies, across an age spectrum and across race and ethnicity. And so the vaccine was issued this emergency use authorization. And when that was issued after there had been more than 2 months of safety data starting from the second dose. Okay, so there was, and for the Pfizer vaccine, it's given every 3 weeks. So 1 shot and then a second shot 3 weeks later. For Moderna, it's 1 shot and then a second shot 4 weeks later. So after that second shot, they had all this safety data. Now, historically, any serious safety issues related to vaccines have always been noticeable within the first 6 weeks of the first dose of the vaccine. And the FDA had more data than 6 weeks. So and since then it's been distributed throughout the world, and there really are no significant safety concerns. And the technology is just so sort of minimalist and simple. There are no adjuvants, there are no food products, there's no live virus. There's no way that the vaccine could lead to infection itself. So based on all the data, which is quite substantial, and based on the fundamental principles of the vaccine, I have really no significant safety concerns. A lot of people ask me, well, my uncle has cancer, he's on chemo, he was told he can't get the COVID vaccine because he's immunocompromised, or I hear all sorts of scenarios like that. And there actually are no contraindications to getting the vaccine, other than if someone has a history of anaphylaxis, which is a severe and immediate allergic reaction to either the mRNA vaccine itself or one of the components that might be responsible for some of the rare anaphylaxis reactions, and that's called polyethylene glycol, or PEG. And that's an ingredient that's very common in a number of medications, including Miralax and other things. As far as anaphylaxis goes, I think we've all heard about the cases of anaphylaxis, although just to put it into context, the odds of anaphylaxis are quite low, all things considered. It's substantially less common than anaphylaxis after penicillin, for instance. So there's a lot of safety data, and the safety data will be continually monitored. So the vaccine trial volunteers will continue to be monitored quite closely, and anyone who's vaccinated is encouraged to participate in some of the various safety monitoring systems, including even a new system such as vSafe. So that's the safety, and I'm sure everyone's heard about the effectiveness or the efficacy. So both the Pfizer and Moderna vaccines in the trials were shown to be 95% effective or efficacious, and that's in terms of preventing symptomatic disease. Of note, in the Moderna trial, there were no volunteers who got the vaccine who developed what was classified as severe disease. In the Pfizer trial, there was one volunteer that they classified as severe disease, but the FDA reviewer actually mentioned that one person with severe disease, in my mind, didn't really have severe disease. They had an oxygen level of 93% briefly, and no other complications. They didn't require supplemental oxygen or hospitalization. So I would say that there were really no severe cases of COVID-19 in those who got the vaccine, at least severe enough to warrant hospitalization. And importantly, these vaccines are 100% effective in terms of providing protection against requiring hospitalization or dying from COVID-19, which I think is really incredible. And I just can't emphasize enough how fantastic these results are. How long does the effectiveness last? We really don't know. Time will tell. So here's a table of some of the vaccines, some 6 of the vaccines, not all of which are available. And just to draw your attention to the column in yellow that shows that of all these vaccines that have been given, no one has gotten the vaccine and then developed COVID-19 that was severe enough to require hospitalization or died, and that's phenomenal. So when we hear, the Johnson & Johnson vaccine was only 72% effective, I think it's important to know, first of all, 72%, that's pretty good. I don't think anyone would have expected these vaccines to be 95% effective like the RNA vaccines were proven to be. The flu vaccine is typically 30 to 50% effective. So 72% effective for the Johnson & Johnson, just as an example, that's quite remarkable. But more importantly, it was 100% effective at preventing hospitalization or death. So I think one big issue that we need to all consider tackling is vaccine hesitancy. It's quite common that people have concerns. I think of it as a spectrum of vaccine hesitancy. So I don't consider someone who's reluctant to get the vaccine necessarily anti-vax, and I don't think people should be dismissed as just anti-vax. Most people that I talk to have very valid concerns. There's a lot of misinformation out there, and it's just very important that they get the right information, and that we, make sure that they understand and have the best information to make the best and most well-informed decisions. But this is going to be, vaccine hesitancy is going to be a significant obstacle to getting as many people vaccinated as possible. So the variants of concern, quickly. So viruses mutate when they replicate. That's inevitable. So that means that when their genome is copied, there are going to be some typos in those copies. Some mutate a lot more frequently than others. RNA viruses, like coronaviruses, mutate more frequently than DNA viruses, but coronaviruses in general mutate less frequently than, say, influenza, which is another RNA virus, and that's because it does have a proofreading enzyme. So it's not known for mutating that often, but because it's been spreading so rampantly for the last year, it's had plenty of opportunities. So when viruses mutate and they acquire a number of mutations and then sort of proliferate, then they have the same mutations, we call that a variant. If they have the same mutations and are clearly known to behave differently, that's when we call them a strain. So there have been multiple variants throughout this pandemic. Quite early on in 2020, there was a variant that was identified that we call D614G, and that just refers to the mutation, which is a change in amino acid sequences. The B1 just refers to a lineage on a family tree of viruses, or of this particular virus. So D614G, that took off pretty quickly and dominated the other variants and became what we now consider the wild type or dominant. It's likely to be a little more infectious than the original ancestor from Wuhan. And then, as we all know, the UK variant, we try not to label variants based on where they were discovered because we don't want to stigmatize those countries. Sometimes the countries are just doing a phenomenal job of actually detecting these variants, and then they get sort of stigmatized as being the origin. So the B117 variant, which involves a mutation called N501Y, that was first detected in the UK in December. There have been a number of different estimates that have ranged quite widely for how much more infectious or how much more contagious it is. The consensus seems to be about 50%, anywhere from 35 to 50%. Initially, there were headlines about it being 70% more infectious. I don't think that's true. And so it's quite rampant now. It's been found in over 70 countries, and we've got 150 cases in California as of February 8th. Importantly, this particular variant, it's most likely to be more transmissible, but there's really no evidence at this point that it clearly makes people sicker or more severe disease. There's no clear evidence. It's to be determined, but at this point, it's not clear that this variant makes people have more complications than the other variants. So then, lastly, the quote-unquote South Africa variant that we call B1351, that has that same mutation as B117 and N501Y. But it also has another mutation that is, I think, the most concerning, and that's E484K. And that mutation seems to make the virus less susceptible to some of the antibodies that are produced by our vaccines. That being said, the mRNA vaccines do seem to be still quite efficacious or effective against that particular variant. And the mRNA vaccines can be fairly quickly adjusted. And again, there's no evidence at this point that particular variant is more sort of deadly or behaves in any other sort of different way. And then the quote unquote Brazil variant is very similar to that one because they had the same mutations. Neither of those, as of yesterday at least, have been identified in California. There is a California variant that we're looking into more, and it's not quite clear, but it seems to be more infectious or more contagious. So far, it doesn't seem to sort of evade the immune system more than the others. It doesn't seem to be more severe. But that variant is making up a greater and greater share of the variants in California. So last I heard, about a third of the variants that have been detected in the area have been this California variant. All right, so hopefully that gave you some of the groundwork. And I don't know if you want to ask any questions now or after Tracy talks.
Thank you, Dr. Scott. Excellent presentation. And it's very positive to see how effective the vaccines are. And like you said, we really need to get that message out to the community. And I appreciate you covering that. One of the questions I received in the chat was, can you talk a little bit about the potential side effects of the vaccine? And are there any reasons why some have side effects and others don't, as far as individuals that get the vaccine?
Yeah, great question. So anytime you get a vaccine, your immune system has to respond. And as the immune system is working, it leads to reactions. Sometimes those reactions are so subtle you don't even notice. And sometimes they're more pronounced or more dramatic. And so that they're often called side effects. I consider them reactions because they are expected, and every vaccine is different. So, after the first dose of either the Pfizer or Moderna vaccine, a fair number of people have pain at the injection site. It is a shot, so most people do have some arm soreness after the first shot. Typically, that's about it after the first shot. So I got both doses, and my arm wasn't any more sore than it was after a flu shot. Some people say it's a little worse than a flu shot. Most of the volunteers in the trials said that it was easier than the shingles shot, those who got both. So in terms of how dramatic the reactions are, I'd say that kind of in between a flu shot and a shingles shot. So after the second shot, that's the booster dose. That's when it's fairly common to have low-grade fevers, chills, shakes, muscle aches, flu-like symptoms. Headache is quite common. And that occurs in about 30 to 50% of people, and to varying degrees. After my second shot, I didn't have any of that. I just had, again, just a little bit of arm soreness. But I think it's very important for people to expect that. And these are not signs that anything is wrong. They're certainly not signs that there's any infection. These are signs that your immune system is working. So I would consider it kind of comparable to after having worked out and having some, muscle soreness. It's a sign that your muscles are working, getting stronger, and in a sense, we're earning our immunity when we have these reactions. They're typically pretty mild. So in the trials, only 1% had severe reactions in terms of severe sort of flu-like illnesses or symptoms. Those symptoms almost always resolve within 24 to 48 hours. I've heard of a few nurses that had symptoms for a few days or even 4 or 5 days. But most people feel perfectly fine after a couple of days. So I would say that, people should expect that. But again, it's a sign that your immune system is doing its job. Does that answer your question?
Yeah, that's awesome. Excuse me, maybe you could unshare your screen so we can see everybody. That would be great.
Oh, sure. And then let me just say one more thing about, let's see here, sorry.
I can actually do it, I think.
Okay.
There we go.
Oh, good. But you asked, who should sort of expect to have more dramatic reactions. So again, because the reactions are a sign that your immune system is working, younger people tend to have more sort of dramatic reactions or more pronounced. So younger adults compared to older adults. So folks over 65 typically have much milder reactions, and that's just because the immune system isn't quite as robust.
Great. Tracy, I think, do we have time for a couple more questions for Dr. Scott? Hopefully Dr.
Sure.
Scott has time.
Just keep going.
A couple more here. Okay. We have a question from Ken Norvell. In trials, what happens with the placebo recipients? Do you know? Dr. Scott?
Well, they're continuing to monitor them. So
Okay.
the vaccine trial volunteers are monitored over 2 years, I believe. So, in terms of whether or not they're now going to get the vaccine because there's a vaccine. Yeah, that's a good question.
I think that's what he's referring to.
Yeah. So they will be offered the vaccine. There's just no ethical way we could not offer that. So, and that could potentially sort of complicate the data overall. But that's it would be hard to withhold that given that there's a vaccine available.
Great. Another question came in. What's being done to get that 58% number up to 80%, which this person believes we need for herd immunity?
Great question. Yeah. What's being done? Not enough, to be honest. There's always so much more to be done when it comes to educating people around the safety, the effectiveness, the importance of vaccines. I did just hear in the news yesterday that Facebook has now taken a stance and is no longer allowing misinformation on their platform. I would say it's a little too late for that. Misinformation has been spreading through social media for several months. There's been a vacuum in terms of communication from our political leaders about the importance of educating people about the safety and efficacy of these vaccines. So we're basically, my point is we're going to have to really catch up. I think it's important for people to let other people know when they got their vaccine, what their experience was like. It's important to see, I think, celebrities and athletes and Dr. Fauci and everyone else get their shots. There are a lot of vaccine selfies out there on social media. And I think it's also really important. So I don't think that the marketing basically has been that great. It hasn't been adequate in my mind about the importance of the vaccine. And scientists are very cautious, and doctors as well, about not overselling something. We want to just give everyone the facts. So I think that we've undersold the vaccine. Not only will it almost certainly prevent hospitalization and death, it will most likely prevent transmission and spread, and that's not emphasized enough. And part of that's just because the data isn't rock solid. But I have every reason to believe that these vaccines are going to significantly slow down or halt the spread of disease. I think that the vaccines are going to be the hero at the end of this story and allow us to get back to our normal lives, allow businesses to reopen, allow grandparents to hug their grandchildren, et cetera. So there's a lot more we need to do from a sort of messaging standpoint.
Great, thank you. Great question here. How much protection do I have after the first shot?
Yeah, great question. So initially there hasn't been that much data, but Moderna data show that it was 52% effective after just the first shot. But that's starting from day 0. And we know that it takes at least 12 days for any of these shots to take any effect. So you don't have any immune protection for the first 12 days. So if you start from day 0, the first shot provides 52% effectiveness. But if you start at day 14, which is more appropriate, then one shot is about 85 to 90% effective. But that being said, both shots are highly recommended for a number of reasons. One, partial immunity, which would be one of the problems with just getting one shot. That's a recipe for producing more variants and more resistance. Another thing is that the 2 shots provide much longer lasting immunity and more effective immunity. So I definitely recommend both of the shots.
Great, thank you. We have 2 more questions, Tracy and Dr. Scott, if that's okay. Kirsten Baranti, would you like to tell Dr. Scott your question, please?
Yeah, I actually have 2 questions. One is related but unrelated. Do you have any statistics so far this year on the flu vaccine, or the flu and the prevalence in comparison to the year before?
Yeah, great question. So one of the most striking things about this last year is that there really hasn't been a flu season. It's incredible. So as an infectious disease doctor, most of what I do is see patients in the hospital who are hospitalized with various infectious diseases. Most years I'll see, maybe 30, 40 patients hospitalized with flu. This year I haven't seen a single patient with the diagnosis of flu. There have been some cases of flu here and there, but for the most part, we've really squashed the flu, and there's essentially no flu season. So is that because the flu vaccine was just a home run this year? Probably not. It might have helped, but I think a lot of it has to do with all the attention to hand hygiene. We're disinfecting just everything to an extreme almost. And the physical distancing obviously too. So everything that we've done to mitigate the COVID pandemic has just worked incredibly well to really crush the flu.
And I have a follow-up question which will actually lead to Tracy's topic, is there's been some discussion, unlike when our children get vaccines, about giving either Tylenol, as adults taking Tylenol and or some sort of ibuprofen, and if you could opine on that.
Yeah, that's one of my favorite questions. Thank you. So there are studies in children that, as you mentioned, that do quite clearly show that if you give Tylenol before a vaccine, that will blunt the immune response. And so then the question is, does that apply to adults? We don't know. There's not enough data. But my belief, based on the fundamentals of how vaccines work and how the immune system works, is that if you can tolerate those reactions, which again are low-grade fevers in some people, not everyone. I didn't have any. But I'm talking a temperature of 100, maybe 101. If you can tolerate that, I would definitely recommend avoiding ibuprofen or Tylenol. The immune system works better at higher temperatures. It makes antibodies more efficiently, for instance. And there's no need to suffer. I think that if you took a little bit of Tylenol, a little ibuprofen, if you were really uncomfortable, that would probably be fine. But I would at least recommend not taking it on a preventative basis or prophylactic basis.
Great. And last question, which is a good closer. For those who have unfortunately already had COVID-19, would you recommend them still taking the vaccine?
Oh, this is another one of my favorite questions. So these are fantastic questions. So once you get the vaccine, I just had some window pop up. Sorry.
Okay.
Once you get infected, you are going to be immune. The more severe your disease, the better your immunity will be. But most people, by and large, are immune for at least 3 months. So for that reason, the CDC says that you can consider delaying the vaccine for 3 months after your infection. What's interesting is that they don't recommend a particular minimum interval. So a lot of people ask me, and a lot of people are getting COVID because it's just so prevalent right now. So it's quite common that people ask me, I got infected 10 days ago. Can I get my shot now? I would say hold off, because if you get it too soon, there's going to be an overlap, and your immune response might not be as good, and it would most likely lead to worse reactions. So I think of natural infection as I think of it like the first dose of the vaccine. So the Pfizer vaccine interval of 3 weeks, that's the bare minimum, because it requires 3 weeks for the primary immune response to sort of settle down before the boost. So if you have a natural infection, I would say wait at least 3 weeks minimum, and up to 3 months. But you should definitely get the vaccine at some point, because immunity from natural infection is probably not that long lasting.
Excellent. Thank you so much, Dr. Scott. Appreciate your time. And boy, I learned a lot just from the things you said. So really appreciate it. Feel a lot better that you're working here at Stanford ValleyCare Healthcare. So I'm going to pass it to Tracy to finish out our conversation.
Perfect. Well, thank you so much. I'm going to share my screen. Hopefully you can see the presentation that's displayed. Yes. I'll look for a thumbs. Okay, great. Thank you. And Steve, I absolutely echo your comments about Dr. Scott. We are really fortunate to have him in the organization. And I too learned several things during this last 45 minutes. And as Dr. Scott, you were talking about the reactions more common in the first 6 weeks, you know, the more significant reactions. I'm just coming up on my 6-week date from my first shot. I feel great. So I'm almost in the clear on that. So I appreciated that. I will confess, as Dr. Scott said, you know, 30 to 50% of folks have reactions after the second shot. I am one of those individuals. I was fine after the first one. Second shot, I actually had a conversation with Steve Van Dorn earlier that day. It was not a great day for me. I'm not gonna sugarcoat that, but it did feel like a mild flu, and I haven't had the flu in years. So I was probably unprepared for what that felt like, but mild fever, about 100.7, chills, headache, and it lasted about 36 hours. So everything that Dr. Scott described, right on the money. I think if I were prepared for that going in, probably wouldn't have surprised me as much as it did. So those that didn't have a reaction on the first shot, don't take that as how you might fare on the second. Still be prepared. Get a couple extra blankets to put near your bed, drink a lot of water, and I promise, 36 to 48 hours later, it'll be like nothing ever happened. So very much, despite the reaction, endorse getting both vaccines for sure. So I'm going to talk a little bit about how you might get a vaccine and talk a little bit about the distribution process that's occurring not only across the state, but certainly here in Alameda County. I'm going to share with you a couple just sort of interesting tidbits, and then I'll open it up for questions. Certainly I want to know what's most important to you. But let me first just sort of piggyback on what Dr. Scott was talking about in terms of just COVID in general. We saw a large peak here in Alameda County towards the end of December, early part of January. No surprises. We sort of expected that, which is why the state and ultimately the county went ahead and put shelters in place during that time period. Since that time period, though, in the last several weeks, we've seen our positivity rates decreasing. We've seen our inpatient cases decreasing, and specifically our ICU cases decreasing. And again, you'll see those trends noted on the graph across all of the 7 Bay Area counties. So that's really promising in terms of the direction that we're heading in and the positive impacts of all of the attention that was given in December with shelter-in-place orders and the like. At Stanford Care-ValleyCare, we continue to have really effective safety protocols in place. We've had no changes to the services that we provide as a result of any surges that we're seeing across the counties and across various cities. We've also added several telehealth options for those services that still can be provided from a remote location, so specifically urgent care, as well as physical therapy. I know Joe Carlucci is on the phone today, so shout out to Joe Carlucci and his team. But interestingly, we've had a lot of really great success providing these 2 services via telehealth. We do have very safe protocols in place should you need to come to the hospital, but in the event that you don't, we can certainly accommodate still that same level of great care. So I'll turn our attention to vaccine and really what's happening across California. And again, as I mentioned, what's happening in Alameda County. What I think was really important for me to share is our data source, where we get this information, because it is so dynamic and continues to change literally every day. You'll see at the very bottom of this particular slide, the COVID-19 website hosted by the state. This is the resource that we utilize to understand how the distribution of vaccines is flowing across the state. And so what you'll see, this data is a little bit old from last week, February 1st. You'll notice that 5.6 million doses were delivered, 3.5 million doses were administered. So you can sort of get a sense of not only volume and order of magnitude, but also the speed with which we're able to vaccinate our communities. Here locally in Alameda County, again, we're able to see off to the right the number of vaccines that were administered within the county. And again, this is as of February 2nd data. So 150,000 vaccines administered through that particular period of time. Vaccine distribution is a complicated process, depending on various healthcare organization, certainly the county, certainly the state. We're seeing a lot of variability across the country. And so I'm happy to answer questions about how we get vaccines or how others get vaccines and where things fall in terms of the distribution process. In terms of the framework, and again, I'll draw your attention to Alameda County because that's certainly where the hospital sits. And so we pay a lot of attention to what's happening here locally. Alameda County has, in accordance with CVPH, designed this framework by which we would move through the various tiers. And so this describes the eligibility, if you will, for patients to be vaccinated. I do think it's really important to note that each county is a little bit different with this speed with which they move through the various tiers. And oftentimes that's influenced by how quickly those healthcare providers can move through the tiers themselves. If a county, and I'll use Alameda as the example, has a larger percentage or a larger number, absolute number of healthcare workers than perhaps another county, it might take Alameda County longer to move through that tier. We're seeing the same conversation happen when we talk about those that are over 65. Counties that have populations of higher populations of individuals over 65 may take longer to move through that tier, and ultimately may take a little bit longer to get through some of the other important populations to vaccinate. So Alameda County, as I showed here, this is directly from their website, has three tiers that are part of phase 1A. Currently, as of yesterday, Alameda County has started to move into phase 1B, tier 1, which is inclusive of individuals aged 65 and older, as well as essential workers within the education and childcare settings, emergency services, and food and agriculture. Within those three particular groups, the county is really focused on how to prioritize those particular groups and is looking to set up pods so that folks in these areas have the opportunity to be vaccinated efficiently and safely. Stanford Health Care-ValleyCare currently is vaccinating individuals age 65 and older, and in accordance with the county and support that they may need, we are poised to respond to their request for us to vaccinate folks as part of almost like an extension of their pod. So we're working very closely with them, literally on a day-to-day basis, to continue to expand the work that we're doing into these particular populations. In the interest of time, I'm going to move through my next slide. And again, to show you a little bit of the information that's currently on the Alameda County website. So again, I put that towards the bottom of the slide, but this shows the individual healthcare systems who have worked with the county to share their vaccination information. So if you are a patient of Kaiser or even Sutter, or Stanford Healthcare, there are individual links that you can access to schedule your vaccine appointment. I can speak specifically for Sutter and for Stanford, where we have a really good partnership with Sutter at the moment around vaccines, and I'll talk about that. But both of these two health systems do offer the opportunity for patients, for community members who are not patients of the healthcare system to get vaccinated. So in particular, Stanford Healthcare does reserve some of our appointment slots for our community, so not necessarily requiring that you're a patient of Stanford Healthcare. So if you visit our website, you'll certainly get more information on that particular note as well. And then you'll notice that within the county, there is a large vaccination site that is expected to open next Tuesday. That'll be located in the Coliseum. So more information will be posted to their website as that site continues to launch. And then I'll talk a little bit about what we've done at Stanford Health Care-ValleyCare with regard to vaccine distribution. We are really proud of our vaccination program and feel that we've done a really good job, not only coordinating with the county, but also getting vaccine into arms, which obviously is the most important thing that we can focus on in terms of the vaccine distribution process. So we currently have a supply both of Pfizer as well as Moderna. We are administering both the primary as well as the booster shots, so as Dr. Scott described, 2 shots. And we began our vaccination program mid-December, focusing specifically on healthcare workers that were part of our Stanford system, as well as our affiliates. And then mid-January focused on making sure we had the opportunity to vaccinate healthcare workers from across the community. And again, we did that in very close partnership with Alameda County. Just a day later, on the 20th, we expanded our vaccination program to include patients and our community residents 65 years and older. And we're doing that in our current location right on the hospital property. We do this in our 5565 West Las Positas building, so adjacent to our emergency department and connected to all of our other clinical services if the need arises. Across the Stanford system, we have multiple vaccination clinics, many of which are in Santa Clara County. We have one additional site in Alameda County, and that's our Emeryville location. And so I'll show you the resource on the next slide, and you have the opportunity to log on and see availability across all of our different clinic sites. What I'm really proud of, and for those that watched the local news last night, you may have heard that Stanford Care-ValleyCare, Sutter, and the county are in partnership to activate a mass vaccination site on the Alameda County Fairgrounds footprint. We are expected to have a soft go live on Monday, the 15th, which will give us the opportunity to sort of test a process where all 3 entities are vaccinating patients side by side. So we think this is a really great value to our community, gives us the opportunity for a large footprint to vaccinate more individuals, but certainly gives us the opportunity to extend our reach beyond just our specific patient populations and have a broader reach within a more diverse community. So again, information about the Alameda County Fairgrounds site will be posted on the Alameda County vaccine webpage as well, and you can learn more in the next couple of days. In terms of what we're doing locally within the Stanford Care-ValleyCare and Stanford footprint, again, I posted the link at the very bottom of the page. This is our resource link for all of our vaccine information across the Stanford system. It's probably the best place to go for information because it is so dynamic. We update our website daily. This screenshot was taken last week, so perhaps updates have been made since then. And I think the best way I can tell you to access this particular site, if you aren't able to copy that particular link, is just go to valleycare.com, which is our ValleyCare internet page. Right at the top, there's a red banner with white letters, and there's a link directly to vaccine information. You'll be taken directly to this particular page. And as I noted here, there's a lot of information about eligibility criteria. You'll notice, again, this is particularly from the end of January, so a lot has changed since then. But in particular, on the right-hand side, there's information about how to book an appointment directly with us. So I'm going to pause there. I know we're right at 1 o'clock, and I will see if there are questions, and I can't see the chat.
Excuse me, Tracy, thank you so much. Really exciting about the fairgrounds. Can't wait for that to start up. I have one question here. Can a non-Stanford Care-ValleyCare person get a vaccination? And if so, how much does it cost?
Oh, great question. Yes, if somebody is not currently a patient with Stanford Care-ValleyCare, there's still an opportunity to receive a vaccination with us. First and foremost, we are following the county tier structure, the framework that I mentioned. So you'll have to first meet the eligibility criteria outlined by the county. And if you go to this valleycare.com website, and again, right at the top banner, click vaccine, you'll be taken to the internet page that you see on your screen right now. And you can go ahead and click book online. If you don't have a MyHealth account, or if you're not a patient, you can go ahead and create an account to go ahead and activate your appointment. Additionally, we do have a phone number where you can call to get some help with scheduling that visit as well. In terms of cost, for our patients, we do bill insurance for just the administration of the vaccine. but there is no patient responsibility. So we will accept whatever payment is provided by the insurance company for the vaccine administration, and no balance bill to the patient.
Great, thank you, Tracy. Bob Tucknott wants to know where can I get a shot and when? I am qualified by several of the criteria that you mentioned.
Yeah. So again, best opportunity would be to connect with your healthcare provider. So again, I offer certainly Stanford Care-ValleyCare as a resource, but if you get your primary care with Sutter or with Kaiser, certainly feel free to reach out to those sites as well. And I mentioned on the Alameda County website, there are different links to each of the healthcare providers. So if you follow those links, you can see who has appointments that are available to meet your time frame. And I think that's one of the most, I'll say this full transparency, appointment availability is based on vaccine supply. So the extent to which we have vaccine, we will go ahead and schedule appointments. I am led to believe that is no different than what's happening at Sutter and what's happening at Kaiser and other systems as well. We currently have a vaccine schedule that runs through this coming Sunday, February 14th. There may be appointments available. I think we just activated some yesterday and will continue to do so throughout the week. So the other advice that I would give is check websites daily. I know that sounds really cumbersome and onerous, but because our vaccine appointments are connected to the supply that we receive, information changes on a daily basis, right? So we open up appointments as we have more vaccine on hand. And then certainly as we look to activate the fairgrounds, we will continue to make appointments available in that particular location. And again, information should be posted, I would say by Thursday or Friday in preparation for our Monday soft go live. We'll run a small number of vaccines on Monday. We'll take a little bit of a break on Tuesday, and then we'll reactivate Wednesday and run for a period of time.
Thank you, Tracy. I'd like to introduce our city manager, Nelson Fiojo, who would like to say a couple words. Nelson, just please unmute yourself. Thank you.
Hi, everybody. Thank you, Tracy, for the presentation. I just, for the benefit of everybody listening in on this presentation, I just need to underscore and reinforce to everybody who's listening and will listen in the future, ValleyCare Stanford is an incredible resource to this community, and something that I think I even took for granted during non-COVID times. They, Rick Shumway, Tracy and her team have really stepped up, not only to initiate the vaccination site that she's referenced on February 15th, but instrumental in the establishment of the COVID test site, in early 2020. So it's been an incredible partnership, and I'm very thankful for it. So just on behalf of the city of Pleasanton, I just wanted to say thank you, and thank you also for the information today.
Great. I'm sorry, go ahead, Tracy.
Yeah. I was just going to thank you, Nelson. I really appreciate that. And I think for me, both personally and professionally, it's really been an honor to not only be part of this organization, but now in 2021 to be the board chair for the Pleasanton Chamber. I think for those of you that were at the installation lunch or had the opportunity to watch the video, I talked about the intersection between the health of our business community and the physical health of our residents and our population. And I think that's so incredibly important always, but certainly now as we're trying to come out of a pandemic. And so I am really humbled to be in roles that have the ability to, in a very concrete way, marry these two objectives. So I think it's a natural fit, hopefully for the chamber and certainly for the hospital as well. So thank you.
Good. Thank you, Nelson, for being here. And Tracy, just one last question from Ken Norval. He says on your website, it still says you have to be a Stanford patient for him for the last 3 years. Is that still correct?
That's a complicated question. And so I'm going to answer it this way. For Stanford Care-ValleyCare, we have not enforced the 3-year time frame historically. And that is because of the relationship that we have with our physicians, our independent community providers who are credentialed with the hospital, as well as with the broader community. I suspect that this will change across the system shortly because what we're starting to see across many counties, Santa Clara in particular, is that health systems are being asked to vaccinate broad populations and not limit to just those patients that are impaneled with primary or specialty care providers. So the short answer is no, that's not correct. And you will start to see that shift in the language on the website.
Great, thank you. I think that's it. We've kind of run out of time. Just can't thank you enough, Dr. Scott and Tracy, for your informative presentation. I'm sure hopefully we'll get a chance to have you do this again when we are experience herd immunity. So thank you so much for joining us. Thank you again for your support. And we will be posting this to our website if you'd like to share it with any of your friends that weren't able to join us, or you just like to watch it again. So there you go. So take care and enjoy the rest of your day. Thank you.
Thanks
a lot. Take care.